PLN.
Good evening all. Welcome to iFocus Online Lecture 291, the 32nd in the Uvea session. Today we have with us Dr. Santosh Mahapatra from JPM Rotary Eye Hospital, Cuttak, on a very special edition of the exam special, the long and short cases in Uveitis. Dr. Santosh Mahapatra did his MBBS from SCB Medical College, Cuttak, MS Ophthalmology from VSS Medical College, Sambalpur, and a fellowship in vitreoretina at Aditya Jyot Eye Hospital. He is currently the Honorary Secretary of the Odisha State Ophthalmic Society and a Chief Medical Officer since 2010 at the JPM Rotary Eye Hospital, Cuttak, Odisha. He has 22 papers in peer-reviewed journals and has presented over 150 papers in state and national conferences. He is a member secretary of the Institutional Ethical and Scientific Committee, a reviewer for the IJO, the Journal of Clinical Ophthalmology Research, and others. He has also been a principal investigator in ripasudil ophthalmic eye drops, olopatadine ophthalmic eye drops, the VMCO1 for retinitis pigmentosa, the ranibizumab and the ranibizumab trials. He is a recipient of the Best Subject Paper Award in the Comprehensive Ophthalmology section at AIOC 2020 and 2021, and also the very prestigious BNR Subudhi Endowment International Award 2021. We are delighted to have Dr. Santosh Mahapatra for this special edition on the exam special of long and short cases in uveitis. Over to Santosh Kumar, sir. Before he starts sharing his slides and having a wonderful session this evening, I would like to make a small announcement that we have a very exciting quiz coming up next week. This is for all those postgraduate students currently online and those who will be viewing the session later, that please gear up for the next week's very exciting quiz by Dr. Parthopratim, Dutta Majumder, and Dr. Abhilasha Baharani. Over to you, sir.
Thank you for the wonderful introduction. I would like to thank Team iFocus and Dr. Santosh Mahapatra in particular to have this opportunity. So very good evening to one and all. I'm here to discuss the long and short cases in uveitis, particularly in respect to exam. So as they say in grade Bhagavad Gita, Karmanya Vadika Rasti Ma Phanesu Kadachana. So go on playing the game without being worried about the results. So you just need to think that I am presenting a case in my own institute and go on starting with the chief complaint, take a good and very detailed history, go through the visual acuity, whether it is improving with pinhole or not, do all the ancillary tests, which includes detailed ocular and systemic examination, draw a good fundus drawing, and try to reach at a provisional diagnosis. So if you take a good history and particularly the chief complaints, just like the well begun is half done, you are halfway to the case. Your systemic examination and ocular examination will give you a direction to formulate a group of conditions called as differential diagnosis. If you have your ancillary investigations, you can proceed to have a definite diagnosis, but in exam, you may not have all the ancillary investigations available with you. So at least you can have a provisional diagnosis with all the information you get by doing all to face your examiner. So the chief complaint will definitely give you a direction, just like if the patient is complains of pain and photophobia with blurred vision, which is of acute onset, most probably you are dealing with a case of acute anterior uveitis. If it is persisting more than 3 months, maybe you are dealing with a case of chronic ileocyclitis. If it is having recurrences and renumeration of the symptoms, and it is more than 3 months of inactivity, you are dealing with a case of recurrent anterior uveitis, and it is associated with flutters. Maybe you are dealing with intermediate uveitis, and with gross diminution of vision, photopsia, metamorphosia, then it might be posterior uveitis. So if there is a pain on ocular movement, you are dealing most probably with posterior scleritis or orbital inflammatory disease. If it is bilateral with gross diminution of vision, you might be dealing with VKH or sympathetic ophthalmia. So uveitis workup start with an elaborate history taking. It includes demography, ocular history like laterality, primary symptoms, duration of symptoms, onset of symptoms, or past ocular history of similar attacks, systemic history like fever or renal failure, skin diseases, joint pain, definitely gives you a clue, including treatment history, whether there is a good response to treatment or the patient is not responding to a particular treatment like medication, systemic steroid, and whether the patient is compliant to the treatment. Also, you need to take history regarding injury, recent surgeries, or personal history or sexual history and preferences. Family history is also of paramount importance in uveitis workup. Like most of the diseases are run in family, like HLA-B 27 positive seronegative arthritis. So diet, domestic and personal factors play an important role and gives you a clue. Just like a history of ingestion of raw or undercooked meat with contact with pets may give rise to a diagnosis of ocular toxoplasmosis or toxocarasis with specific findings. A history of exposure to soils or rodent urine may give rise to a diagnosis of leptospirosis when particular findings are associated with it. Ingestion of pasteurized milk or tuberculosis can give rise to a diagnosis of tuberculosis or brucellosis, and thorough sexual history can give rise to a diagnosis of HIV, syphilis, or other STD-related uveitis. So as you can see here, this is table from Paulson always gave us a clue regarding differential diagnosis of 3 most common conditions acute red eye, like conjunctivitis, acute anterior or angle closure glaucoma, where you have almost nil visual complaint with mucopollular discharge in conjunctivitis, a mild reduction in vision with pain, photophobia, and acute anterior and a shallow anterior chamber with increased IOP and blurred vision in angle closure glaucoma. So you need to stick to the basics. Along with all the 3 common conditions I told, you may be also dealing with a condition like episcleritis or scleritis when you are dealing with an acute red eye. And you need to differentiate conjunctival congestion and ciliary congestion whenever you are seeing a red eye. So when we proceed, we need to proceed in step ladder manner, like pain and redness photophobia, which is of acute onset and is severe, having a history of arthritis or back pain, may be a case of seronegative spondyloarthropathy. If it is having orogenital ulcers, maybe a case of Behçet's, or having a history of surgery or trauma, maybe a case of infectious endophthalmitis. If it is of moderate severity with shortness of breath, tender rashes over sins or indurated lesions over nose or cheek, you may be dealing might be a traumatic iritis or is having raised IOP. You might be dealing with a case of glaucoma cyclic crisis. If it is chronic in nature with minimal redness, pain, with arthritis in a child, you might be dealing with a case of juvenile rheumatoid arthritis. If you are seeing a heterochromia of iris with diffuse stellate capes, you can start diagnosis as Fuchs heterochromatic hydrocyclitis. If it is post-surgical, it may be a case of low-grade endophthalmitis. After taking a thorough history, you have an idea where you're going, but your direction is specifically decided by a thorough systemic and ocular examination. And you just need to note down exactly what you are seeing in this systemic ocular examination. So if you are seeing skin lesions like nodules, you may be dealing with SLE, leprosy, sarcoidosis, or a rash in syphilis disease or victus. Erythema nodosum, specifically seen in sarcoidosis, tuberculosis, Behçet's disease.
Dr. Santosh?
Yes.
A small request. Your video is freezing. Your voice is okay. If you can just stop the video till the time the presentation is there, so that the voice doesn't get distorted. I think there is a bandwidth issue at the end. Just stop the video. Just stop the video till the time presentation is there.
Okay.
That way it will consume less bandwidth. Thank you, sir.
Okay. Am I audible now? Better?
Yes,
perfect, sir. Crystal clear, sir.
Thank you. So during systemic examination, you need to specifically see the CNS, where you can have headache, neck stiffness in case of VKH, or auditory symptoms in VKH, cranial neuropathies in multiple sclerosis, or cerebral vasculitis in APMPP. So you need to also examine ear, nose, and throat in specific, like a bilateral ear infection, penile inflammation in relapsed polychondritis, saddle nose deformity in syphilis or leprosy, sinusitis in Wegener's and sarcoidosis, lymphadenopathy in lymphoma or HIV, and tinnitus in VKH or vertigo in VKH. So cough or breathlessness can be seen in pulmonary diseases like tuberculosis, sarcoidosis, or pneumocystis. Abnormal bowel habit can be seen in Crohn's or ulcerative colitis. Genitourinary system examination is of paramount importance when there is a history of sexual contact, like Behçet's, Richters, or syphilis, and other conditions like nephritis, where you can get a direct clue from it. Visual acuity is of paramount importance, and you always need to note the vision with pinhole or best corrected visual acuity, where you can catch the culprit. And if it is improving with pinhole, then there may be a problem in the media. If it is not improving with pinhole, then you may be dealing with a condition where there is a problem in the macular optic nerve. If it is mild impaired without floaters, probably your diagnosis is acute anterior uveitis. If it is moderately impaired with flutters, you are dealing with intermediate uveitis or complications of intermediate uveitis. If it is vision is grossly diminished, you are dealing with posterior uveitis with CME or a panuveitis. So slit line examination is again of paramount importance, as they give you specific clues. Vesicles, nodules, polyposis, or madarosis are specific conditions where you can get at a diagnosis like rickets in polyposis. Granulomas will give in conjunctiva will tend to give a diagnosis towards granulomatous uveitis. Herpes zoster lesions in cornea will give you a diagnosis of herpes zoster related uveitis. your iris will or pupil will give a definite clue regarding RFPD or myotic pupil. And the iris nodules may be specifically looked into. Anterior chamber is of paramount importance in a workup of uveitis, where you need to see the aqueous cells, flare, hypopion, or hypema. And you need to follow the specific criteria by Sun to grade the aqueous cells of flare, where you need to see the cells of flare with 1 into 2 mm beam with highest possible illumination and grade it. Keratic precipitous definitely give you a clue. So if it is in Al triangle, it is acute anterior uveitis. If it is diffusely distributed, it's fuke. Or if it is small endothelial dusting in non-granulomatous uveitis, large bottom cap fat capes give a diagnosis chronic or granulomatous uveitis, and stellate capes in fuke syndrome. Pigmentous capes in a vertical linear manner give a diagnosis of pigment dispersion syndrome. So these are the different pictures of capes, and if it is a granulomatous cape, then your diagnosis is specific, like tuberculosis, syphilis, sarcoidosis, leprosy, herpetic rickets, or sympathetic ophthalmia, or lens-induced uveitis, or a parasitic infection. Non-granulomatous uveitis have a diagnosis of others like traumatic, Behçet's, leptospirosis, and sometimes sarcoidosis or tuberculosis. So careful ocular examination, you can reach a near diagnosis. The ocular symptoms only will give rise to different conditions where you have like vesicles over forehead, or sectoral or patchy iris atrophy can give rise to a diagnosis of herpetic uveitis. Previous history of tuberculosis or ingestion of unpasteurized milk or sclerokeratitis gives rise to syphilis, or tuberculosis of Hansen's. History of trauma gives rise to traumatic uveitis, or a previous history of cataract surgery, maybe a lens-induced or uveitis. And if it is unilateral in a young adult male with heterochromia or posterior synecdoche or a specific type of capes, you are dealing with FUS. Joint pain gives rise to specific diagnosis, like if it is a middle-aged person with joint pain, you might be dealing with a seronegative spondyloarthritis or vascular disease. If it is associated with conjunctivitis, it may be a case of reactive arthritis. If it is associated with shortness of breath, skin lesions, case of sarcoidosis, or if it is associated with nodules, cough, you are dealing with a case of, it might be a case of tuberculosis. And if there is no joint pain with ocular findings, you may be dealing with Mahendradas syndrome or Crohn's or ulcerative colitis. If it is associated with flutus, most probably it is intermediate uveitis. Associated with tick exposure, it may be a Lyme's disease. If it is having multiple neurologic symptoms, it might be a case of multiple sclerosis, or in elderly person, always need to suspect a intraocular lymphoma. If it is associated with anterior uveitis, snow banking, then definitely intermediate uveitis need to be considered. Other differential diagnoses, including toxocara, ripples, and toxoplasmosis, also need to be considered. If there is associated marked diminution of vision, most probably we are dealing with a posterior segment involvement, or which can be vitritis only, retinitis only, or choroiditis only, or a retinitis, retinochoroiditis, or a panuveitis. Whitish lesions in the fundus with ill-defined border, superficial lesions with relatively more vitritis. Then it is a case of retinitis. If it is focal, it can be a case of toxoplasmosis, onchocerciasis, cysticercosis, or muscardus. If it is multifocal, it can be syphilis, prawn, or candida, or Cuttak disease. If the fundus findings in focal lesions like this one, where you have a punched out lesion with posterior pole involvement with a old scab, most probably it is toxoplasmosis. A lesion in the posterior pole with granuloma, then it might be a toxocariasis. So if it is associated with keratitis, snowflake opacities, and you are seeing a microfilaria, either in AC, cornea, or vitreous, it may be onchocerciasis or a conjunctival or subretinal cyst with exudative RD. It can be a case of cysticercosis. If it is a multifocal lesion which is having involvement of the vessels with lot of extensive exudation, with optic nerve involvement, frustage bands, anxieties, you might be dealing with CMV retinitis. If it is having multiple lesions with extensive involvement of the retina and crack mud appearance, you might be dealing with progressive outer necrosis. If it is having peripheral lesions with multiple infiltrations with specific orphitic lesions, you might be dealing with acute retinal necrosis. So numerous small, ill-defined, deep gray white lesions in sparing fovea is characteristic of multiple evanescent white dust syndrome. In a case of acquired syphilis, you may have multifocal retinochoroiditis. Or if it is associated with a history of cat scratch, you are dealing with a condition called cat scratch disease. If the lesion is yellowish lesion with a well-defined border, deeper to the retinal vessels with a relatively less vitritis, you are dealing with choroiditis. If it is focal with vitreous cells, it can be a case of tuberculosis or toxocara. If it is without vitreous cells, it may be a sulpigenous choroiditis. It may be multifocal in different conditions like white dust syndromes, sulpigenous choroidopathy, or Bart's choroiditis. If you have fundus finding like vitritis secondary to anterior, intermediate, or posterior foci with multifocal lesion, then it can be a tuberculosis. We'll come to specific conditions like tuberculosis, sarcoidosis with specific examples. But if you are having candle wax droppings, strong up pall appearance with snowball opacities, with venous involvement in specific, with pulmonary symptoms and nodules, you are dealing with sarcoidosis. So you also need to differentiate a case of TAS or bacterial endophthalmitis in a postoperative case. So as you get these clues, you just need to join the bits to reach at a diagnosis, and the differential diagnosis will be formulated with all these clues you have drawn from hypopyon, iris pattern, atrophy, or different types of capes. So uveitis with different infectious etiology or non-infectious etiology like sarcoidosis Behçet's, which involves the vasculature of the retina, can be derived with specific clues. So we'll deal with specific case scenarios where situations you can stamp the diagnosis without ancillary investigations. Like this one with a child, predominantly it is a male child with arthropathy and rashes with anterior uveitis, which is chronic in nature. It is most probably a case of juvenile rheumatoid arthritis. So here is a case who is a 52-year-old male with gradual diminution of vision in both eyes for a duration of 2 months without any fever, weight loss, lymphadenopathy, or contract history, with multiple lesions in the fundus and a positive pathogen test with orogenital ulceration. This is a case I dealt with, is a case of Behçet's syndrome. So you need to have, if there is complaint of insidious onset of blurred vision with micro and this type of clinical picture, I think you are dealing with a case of VKs where you have specific clues as already extensively discussed. So this is a case of leprosy with specific dermal lesions and saddle nose deformity, leonine facies with acute anterior uveitis involving both posterior part and vitreous. Then you are dealing with a case of leprosy. So here is a case where you have specific lesions like alphabetical lesions over the forehead with anterior uveitis. You are dealing with a case of herpes zoster ophthalmicus. So investigations need to be done in a tailored fashion based on the history and clinical findings. Careful review of systemic symptoms is essential to detect underlying disease. So investigation of anterior uveitis is only indicated if it is recurrent or severe in nature or bilateral and in a granulomatous uveitis. So you need to do a multiple number of investigation, which includes CBC, ESR, CRP, serum AC, ANA, or specific like HIV, ANCA, or others, depending upon the specific case scenario. Also, HLA typing only when it is needed. Ocular imaging is of paramount importance, but they need to be directed towards the cases, which include B-scan, OCT, fundus autofluorescence, or angiography, ICGA, or UVM as and when required. Aqueous tap, which can be done with for PCR or microscopy and culture if it is specifically suspected to have viral etiology, or vitreous biopsy in case of obscured posterior segment inflammation or suspected infectious endophthalmitis. Conjunctival biopsy sometimes can be helpful if it's a granulomatous uveitis and you have a conjunctival granuloma. Ancillary investigation like HRCT, whole body scan, or bronchoscopy, or MRI, or lumbar puncture is case-based and needs to be ordered only when it is indicated. So the case scenarios from our institute, where this is a female who was referred to us with a already diagnosed case of miliary tuberculosis with a positive skin test, and he had a specific lesion like this with a large tubercle here and few small tubercles, which is seen in bilaterally in her case. This was a case of tuberculoma, and it's a stamped case of ocular tuberculosis. Radiology sometimes helps in these cases of biliary tuberculosis where you may have CNS tuberculosis, or you can have a pulmonary involvement also seen on HRCT thorax. So this is a 31-year-old female which I have last seen today only with a serpiginous like choroiditis with a history of present diminution of vision, and you can see here the complaint of diminution of vision already completed ATT, but here you are seeing a secondary CNVM. So this is serpiginous choroiditis with complication, and syphilis is a great masquerader where you may not be suspecting it, particularly in this era, but always you need to advise VDRL or TPHA to stamp the diagnosis where you are not getting any clue. You may not be seeing maculopapular rashes in few cases. I have 7 case series just going to be published, but many cases you are not getting a clue, and always you need to do a order for a investigation. This is another case where you are directly getting a headlight in fog appearance with a history of contact with pet, and this is the case of toxoplasma. So where this is another case where you have candlewash droppings, periphleboitis, chest X-ray showing hilar lymphadenopathy, this is a rash, and all these are very specific of sarcoidosis. So another case of a 28-year-old male with multiple exudates around the posterior pole with few hemorrhages. He had no history of fever, but there was RFPD. All the tests like HIV, toxo, viral, Mantux came negative, but PCR for CNV was positive, and he was a stamped case of CNV retinitis. This is a case of history of past history of fever and referred to us for ophthalmic examination with a positive dengue serology, and you can see multiple white retinitis patches bilaterally, which is confirmed on angiography and responded well to steroid. This is a bilateral anterior uveitis with a positive Mantux ESR of 40 and responded well to ATT. Came for a follow-up today only. A case of bilateral panuveitis, but he had also a positive HLA B27, and might be it's a case of tubercular panuveitis with a seropositive ankylosing spondylitis, and it is a case of chronic uveitis with CME dealt with posterior steroid. This is a 36-year-old female with a complaint of pain on ocular movements. There was the anterior segment was almost normal with a visual acuity of 636, and had a disc edema with elevation of the posterior pole of the retina on B-scan, has a T sign stamped as a case of posterior scleritis. So principle of management is specific to the etiology, like ATT for tuberculosis, parental penicillin for syphilis, and sulfa and pyrimethamine for toxo, and antiviral therapy for viral uveitis of viral etiology, and non-specific like cycloplegics, corticosteroids, or of uveitis of non-specific etiology. So if you progress in a systematic manner, in most of the cases you can reach at a diagnosis. Like if you have can have cases like tuberculosis, syphilis, leakage, or Behçet's or scleritis as major cases. You may be facing a case of acute anterior uveitis or episcleritis as or just a fundus picture where you will be asked to draw a fundus drawing as a short case of uveitis. So you need to have a very methodical, specific approach and need to chip in your specific findings, starting from chip complaint to history to systemic and ocular examination, so that you can chip in each and every information to reach at a provisional diagnosis. The examiners may also ask for ancillary investigations you order for this particular test, and your ancillary investigation need to be directed towards the case specifically depending upon the findings you are getting. You tell I'll use cycloplastics, and you can be asked in which way it is going to help you, and you should be promptly answering like it prevents breaking of the synechia or release of the synechia, and also reduces pain due to vascular spasm. So all these treatments which are being given in cases of uveitis, like corticosteroids, when it is indicated, and when you need to switch over to immunosuppressives or biologics, need to be specifically dealt with, and you need to answer very specifically to your examiner when you are facing the exams. So with this, I think we can close the presentation, and I think we can have discussions for queries raised by the students or any panelists.
Yes, sir. Thank you so much, sir, for taking us from pole to pole of the eye with such beautiful collection of pictures and handcrafting the slides for all the postgraduate students. I'm sure they'll benefit a lot from this presentation today. We also have a lot of questions for tonight. I should start
just a little just to
now,
allow more questions.
Yes, sir. So thoughtful of you, very kind, sir. I shall be taking the first question now. How do we evaluate a patient presenting with a complaint of colored halos and a red eye?
Yes, I have just discussed that in a very my slide, which tells us stick to basics. Colored haloid and red eye. I think you should first differentiate between acute conjunctivitis. Colored haloid and red eye will give three conditions. I think you may have colored halos and a red eye. One is mycopurulent conjunctivitis. Second is acute congestive glaucoma, and your uveitis, where you need to differentiate each condition. Like in mycopurulent conjunctivitis, the vision will be grossly normal. You can have a mycopurulent discharge, and in acute anterior uveitis, you'll have cells and flare with moderately decreased vision, and in acute congestive glaucoma, you will have a shallow anterior chamber with raised IOP, and you can do a Fincham test, which will differentiate the fourth condition like a cataract from the acute congestive glaucoma.
Yes, sir. Moving on to the second question. When do we perform a gonioscopy in case of uveitis?
Doing a
Gonioscopy in a case of uveitis.
Yes. You can do a gonioscopy if the patient is not in very much pain and you are also suspecting angle closure. If the patient is in pain, it will be like difficult to do a gonioscopy where you have to put a contact lens.
Yes, sir. Moving on to the third question, sir. Can you please explain the correct methodology for counting the cells in the anterior chamber in a case of anterior uveitis or intermediate uveitis?
The cells in the anterior chamber may be seen both in anterior and intermediate uveitis, but you need to look for pars planitis or snow banking or snowball with fully dilating the pupil and doing a indirect ophthalmic level. You will detect the snow banking and cotton balls in intermediate uveitis, but in anterior uveitis you may not have these findings. And also, if you also look for the symptoms like floaters, where you can see in intermediate uveitis, but in anterior uveitis you may not have symptoms like floaters.
Okay. So they've asked, what is the correct methodology to count the number of cells in the anterior chamber?
It is very specifically described in SON classification, where you need to have a 1x1 millimeter slit with the highest possible illumination on the slit lamp, and you need to focus that in the anterior chamber with a dimly illuminated room and count the cells visible on a specific with these specific conditions.
Thank you, sir. Moving on to the next question, sir. How do we clinically differentiate a case of toxic keratouveitis versus anterior uveitis?
Toxic keratouveitis will have involvement of both cornea and anterior chamber, and it is usually toxic to either some chemicals or cosmetics or drugs. You will have corneal lesions like epitheliopathy or corneal edema, along with uveal inflammation, anterior segment inflammation like cells flare or hypopyon in anterior chamber. But in only uveitis, you will not have corneal involvement. You will have cells flare in the anterior chamber or hypopyon, sometimes if it is acutely inflamed and of higher degree. But corneal involvement will not be seen in anterior uveitis. Only in case of secondary glaucoma, you may have corneal edema in that case. But primarily, if it is a keratouveitis, you will have involvement of the cornea first, followed by uveal inflammation. But in case of anterior uveitis, you will have primary involvement of the iris and ciliary body. Secondary corneal edema may happen in the later stage.
Yes, sir. Very true, sir. The next question, sir. How do we differentiate a retinal vein occlusion with exudation in immunocompromised individuals with the absence of anterior chamber signs between a CMV retinitis versus an Eales disease?
Yes, very good question. I think in a immunocompromised individual, you mean to say he either HIV positive or any debility related. That case, if it is there is a vasculitis with a lot of exudation in the posterior pole, along with positivity, say, of CNV in PCR or other virologic investigations, then it is definitely CNV retinitis. And the second part is retinal vasculitis. In an immunocompetent person, it can be due to tuberculosis or other causes, or it may be idiopathic also, as in Eales disease, where your serology for CNV will be negative, and it may have a positive Mantoux if it is tubercular vasculitis, or it may, all the tests may come negative in case of a idiopathic retinal vasculitis, in contrast to CNV retinitis, where your CNV serology is positive.
Okay, sir. The next question is, how do we clinically differentiate between retinitis versus retinochoroiditis versus chorioretinitis?
Yes. Just in the presentation I described, retinitis is a inflammation of the retina only, where you will see a ill-defined yellowish white lesion in the retina with associated vitritis. You will have vitreous cells and flare over the patch, and you may have diffuse vitritis also. In case of choroiditis, you will have a lesion which is relatively well demarcated below the retinal layers, and you can see the vessel running over the lesion, and you will not have associated vitritis in the initial phases till it involves the retina. So this is choroiditis, and if it is a retinochoroiditis, you will have start with retina. The inflammation spreads to choroid, and if it is a chorioretinitis, is the reverse. The inflammation starts in the choroid and involves the retina. Once it is involved the retina, vitritis is bound to have in a focal manner, initially over the retinitis patch, and later on it may have spillover vitritis all over the vitreous.
Okay, sir.
Basically, you can definitely differentiate between retinitis, choroiditis, retinochoroiditis, or chorioretinitis.
Yes, sir. Point well taken, sir. The next question, sir. What all points to look for in a systemic evaluation of a pediatric uveitis case?
Yes, in case of pediatric uveitis, again, it depends upon the age of the patient, where you may have a congenital infection like rubella, where you need to look for serology of the mother and the child, as well as you also need to, in a little older child, you can also look for history of joint pain or joint swelling, along with nature of the uveitis, whether it is acute or insidious onset, or chronic, or recurrent, or relapsing. And if it is associated with joint pain in a little older children, it is a case of juvenile rheumatoid arthritis. If it is a younger child with positive serology for torch infections, then you may be dealing with rubella or cytomegalo or other cases of uveitis.
So one student has asked, how do we approach a case of painful loss of vision?
Yes, this is already very extensively I have discussed. Painful loss of vision is associated, like if it is specifically most probably a case of panuveitis, where you have anterior uveitis, which gives rise to pain. Then vision loss is due to vitritis as well as posterior uveitis. So you need to thoroughly investigate it as a case of panuveitis and need to establish a cause, starting with your systemic examination and specific finding. If you are able to delineate any specific finding, like I said, in a case of VKH, you may have headache, you may have polycyst, you may have auditory symptoms, or you may have other systemic signs. But you need to relatively find out the associated systemic presentation, as well as order for specific investigation to rule out other causes. But full decrease in vision, most probably it is a case of pan-uveitis, and you need to thoroughly approach it in a stepwise manner just described.
Yes, sir. So the next question, which subset of uveitic cases are likely to have a scleral involvement?
Can you please repeat?
Sure, sir. Which subset of uveitic cases are likely to have a scleral involvement?
Which subset of uveitic patient
are likely to have a scleral involvement?
Okay, it is mostly rheumatoid arthritis and other collagen vascular diseases which may have scleral involvement, along with juvenile rheumatoid arthritis, polychondritis, or other collagen vascular diseases, which definitely can have scleral involvement. So all those cases which are positive for rheumatoid factor needs to be carefully investigated along with ANCA or other serologic markers for diagnosing the case in particular, like myositis, other polychondritis. All these cases can have scleral involvement.
Yes, sir. So the next question is the differential diagnosis for a multifocal choroiditis.
A differential diagnosis of multifocal choroiditis is a long list, starting with tuberculosis to VKH to acute MPP, multiple evanescent white dwarf syndrome, any infective cause like viral etiolus. So multifocal choroiditis has a long list of differential diagnosis, but you need to again do a thorough systemic and ocular examination, as well as try to find pertinent history related to a particular case to reach at a group of differential diagnosis and order for ancillary laboratory test to reach at a provisional diagnosis.
Yes, sir. So the preferred cycloplegic in a case of acute anterior uveitis.
Preferred in the case of
acute anterior uveitis. Preferred cycloplegic agent.
It depends upon the amount of synechia present. Preferably, you give cyclopentolate, but sometimes you also may need to give atropine or homatropine, depending upon the synechias and its adhesion and duration of it. But a cycloplegic agent which is enough to relieve both the pain as well as release the synechia is the preferred agent in a particular case. Most of the time it is cyclopentolate, but it can be titrated according to the need. It may be homatropine or atropine, depending upon the clinical scenario.
Yes, at this juncture, it is probably important to mention for all the postgraduate students that in their examinations, they would be mandated to know the concentration of the drugs being used.
Yes, that's what yeah.
So the next question, how do we clinically differentiate between snow banking versus a snowball opacity?
Yeah, snow banking is nothing but settling down of the exudates in the pars plana region inferiorly. So it is a layer of exudates which have settled down in the inferior pars plana. But snowballs are exudative balls which are seen on the surface of the retina, and they are discrete. maybe single, maybe multiple, but it is seen not in the personal region only. They can seen in the different parts of the retina, more in the peripheral part of the retina. You need indentation to look for snow banking. You can see snowballs without indentation also.
Yes, sir. So the preferred method for measurement of the intraocular pressure in a case of uveitis with corneal edema.
It is always applanation tonometry, but if it is painful, then you can do a other like eye care or AirPof. But the most preferred method is definitely applanation tonometry.
Okay. So characteristic fundus findings in a case of VKH.
Can you please repeat? I just lost your voice.
Okay, sir. So the next question is characteristic fundus findings in a case of VKH syndrome.
Yes. Characteristic fundus finding in acute case of VKH is a multifocal serous retinal detachment along with optic disc inflammation. That means elevated optic disc with filling of the cuff with hyperemia in acute cases. And if it's a long-standing VKH, you may have pigmentation or a tigroid fundus along with different levels of pigmentation.
Okay, sir. So the next question is, what is Wesley's ring? How do we look for it?
What is?
Wesley's ring, and how do we look for it?
Yeah, Wesley's ring is if you have a PVD, complete PVD, then in the posterior pole, you'll have a circular ring, which is finding seen in fundoscopy, either indirect ophthalmoscopy or slit lamp biomicroscopy with 90 degree, and it is usually moves in front of the optic disc or macula on the posterior pole, and it's a completely circular ring-like structure which is movable and can be well seen with a good indirect ophthalmoscopy. It can be appreciated well with other methods of fundoscopy also, like slit lamp microscopy or even direct ophthalmoscopy.
Yes, sir. Sir, two students have asked certain questions pertinent to the exam in a presentation of a long case where we particularly encounter a very long history. How is that we cut down on our history taking time in the examination?
Yeah, when it can be cut down if you take a very specific pathway, like suppose the chief complaint of the patient is acute redness, pain and blurring of the vision, then definitely we're dealing with case of acute anterior uveitis, and you need to ask whether this is associated with specific things like joint pain or rashes or fever, or you have a family history of it. So you need to ask pertinent question rather than just following the logbook I have shown. So you may not be able to complete the history taking by the time your time is over. You need to ask the pertinent questions related to the chief complaint and your systemic and ocular findings. You might have missed some history, but when you go on examining and find something specific like a poliosis or a auditory symptom, you may need to ask related question. And on ocular examination, if you are seeing a oral ulceration or a genital ulceration, you need to also ask the yes, sexual habit or sexual history of the particular patient. So you need to titrate your history taking in such a manner that you need to ask the pertinent questions and avoid unnecessary questions so that you can save time as well as you can get into the case in a specific direction.
Yes, sir. So with that, we come to an end of all the marathon long questions for this session today. Thank you so much for sparing your time and very elaborately and patiently explaining all the doubts of the students across the online platforms of YouTube, Facebook, and also on the personal chat, sir. Before we conclude for today, we have a small announcement to make. The next we meet on 31st of March for the Uvea Grand Quiz by Dr. Parthopratim Dutta Majumder and Dr. Abhilasha Baharani. I request all the postgraduate students to gear up for the quiz next week and join in as in large numbers as much as possible. It is going to be a fun time with learning. Please join in on 31st of March.